Flanagan study, we all know it, randomizing folks to watchful waiting and immediate TURP, prompting the question, does the decision matter to intervene? And it confirmed what we all suspected when we saw the failure rate double with watchful waiting, as we see that go from 28 to 58. But it revealed the deeper consequences of disease progression. Stages 1 and 2 increased from 1 to 13. Stage 3, incontinence doubled. Stage 4 and 5 nearly quintupled. So yes, the decision to intervene matters. Moreover, the timing of intervention also matters. If we look at that third cohort, delayed TURP, 27% of those who were observed underwent delayed TURP, and they did not fare as well as the immediate TURPs. Then the upstream trial, randomizing folks looking at the impact of preoperative multi-channel urodynamics on deobstruction. But they also identified who were the most suitable candidates for surgery. And it was not those in stage 5 with weakened bladders. It was not those in stage 2 and 3 with overactive bladders. It was those in stage 1, early stage, with clear obstruction, when we have the best chances of rescuing those bladders before there's irreparable damage. Unlike at the other end of the spectrum in stage 5, when we look at the Mitchell study in 2014, 19 patients with atonic bladders on multi-channel. And despite maximum deobstruction, achieving some salvage of contractility in the majority, we were too late for 21%, 1 in 5. These data underscore a painful truth. This is all preventable if we had only intervened earlier. And we can. Your generation, have a dialogue about bladder health screening men starting at the ages of 45 to 55. Let's start thinking about Qmax as the next vital sign for men, like BP is for hypertension. Let's also discuss the triangle of triage, where we can identify bladders at risk for dysfunction if they meet these criteria in isolation or in combination. Stage 3 urgency incontinence, stage 4 retention, IPSS 8 and above alone, or in combination with slow flow, high residual, thickened bladders, or unacceptable risk on bphtool.com. These data trigger bladder health baselines with a minimum of cystoscopy up to a maximum of multi-channel advanced urodynamics. The other truth we need to really embrace is that BPH drugs are not treating therapies for benign prostatic obstruction. They are temporizing measures that buy us time to triage. We're not anti-drug. Just like in sepsis, antibiotics can treat. Similar to brain tumors where medications can temporize and surgery can treat, deobstruction is the mechanical solution to the mechanical problem of benign prostatic obstruction. And these changes in perspective on BPH drugs are not just something that we want, it's something patients want. 2/3 aren't taking their drugs, so they don't satisfied. They're interested in alternatives because of the side effects, cost, inconvenience, and marginal improvement of medications. As Defender Cindolo in Italy says, stop narcotizing bladders. But what about the evidence-based combat trial? We salute, we applaud. Combination therapy does a great job of temporizing and reducing risk by 66% out to 4 years as compared to tamsulosin alone. With that said, inductive reasoning, and this goes to your talk, grounded theory, making the observations, making qualitative research taken out to 10 years, the risk is never eliminated. 1 in 10 combination, 1 in 3 tamsulosin are still at risk for stage 4 retention and surgery. BPH drugs are simply sweeping the problem under the rug as we kind of sidestep the issue to deal with it later when the disease has progressed even further. And we see that in the Young study in 2018. BPH drugs are jeopardizing bladder span. They looked at all these TURPs over 3 years, over 2 decades. With the patients on medications increasing to 43%, we see surgery decrease by 65%. Early on, 2/3 of surgeries are happening for early stage LUTs. By 2010, we see this alarming shift to now 2/3 are having surgery for stage 4 retention. Of more concern is the 6-fold increase in failure to void despite deobstruction, suggestive of stage 5. So yes, defend the detruser. If you prescribe drugs, triage to deobstruct earlier. Stopping this assault on bladders starts with shared decision-making with symptom scores. And this one size does not fit all. There's IPSS, widely used, single page, men only, learn, great question on incontinence, ICIQ, multi-page comprehensive question about retention. Please use these validated questionnaires based on symptoms. Man vs. Prostate, in support of academics, launched the communication tool based on bladder health. The International Bladder Prostate Symptom Score, single page, designed for community urologists. Bladder is in the title to ensure its preferences and values are considered. The IPSS and quality of life questions were kept and left 100% the same, just simply reordered to mirror the voiding subscore stage 1 BPO, the storage subscore stage 2 OAB. We then added 2 questions. Learn for stage 3 incontinence. Have you ever leaked urine or wet a pad after feeling that sudden need to urinate? ICIQ for stage 4 retention. Have you ever been unable to urinate and needed a catheter to drain your bladder? The total IBPSS score is identical to the IPSS for continued comparative academic research. This vertical sequential layout mirrors the horizontal stages to empower patients to diagnose themselves and share decision-making and pinpoint exactly, hey, where am I now in the present and where can I be in the future? Igniting them, if they choose, to take action about protecting their bladders. One more question about quality of life, sex, to prompt that discussion because it's taboo subject in so many cultures for so many men. In the last month, have you had erection or ejaculation problems? Now translated in over 10 languages, Chinese, Swedish, Korean. This is just one more tool for you guys to build your data-first, pro-diagnostic, bladder-centric care pathway. As Man vs. Prostate's here to support you with free access to the ebook, our IBPSS's educational videos, dive deeper on LinkedIn, or with our book on Amazon, or with our recent review that just came out last Wednesday. To conclude, let us be the change we all seek. Choose data over drugs. If you prescribe drugs, then triage and obtain those bladder health baselines to deobstruct earlier within that window of curability, to preserve bladder health, to extend bladder span. Make our vision a reality of all of our patients living their best lives incontinence-free and catheter-free, to prevent late-stage disease for this amazing non-transplantable organ. Lean into protecting bladders. We are, all of us, all of you, are defenders of the detrusor. So let's go save more bladders. This concludes what I have to say. I just want to say that thank you all for hosting me this last day and a half. It's been energizing and hopeful, and I look forward to similar actions frequently in the future.
Congratulations on all the achievement you're doing. Your presentation is not only scientifically at a very high level, but the way you present can be a role model of how a message can be done between using the hands, the speech, engaging everybody. So if we were to take notes of how you want to be in public speech, Dr. Kwan today presented all the list of how we can do that. So congratulations on
Very kind.
that. Back to this
Yep.
achievement. I mean, this is great. We want to focus on the big picture of the patient, not just one organ we're treating. That's what I hear you saying. Patient come for BPH, enlarged prostate, and we only focus most of the time on that organ, not realizing that even the kidney is affected and everything is related. It's psychology. You can do whatever you want. Most of the studies you presented are comparing intervention versus medication based on TURP. But the TURP is a fading art. And now we have much more effective ways to open that prostate. TURP, when I would go back 10 years, use the specimen frequently was like 2-3 grams after TURP. So we're basically making a tiny hole. So I'm really opening that prostate. So how do you think that will be impacted by all the big shift into HOLA, aquablation, and other treatments?
Well, that's why we talk to you guys. It's going to be prospectively done when we look at enucleations, regardless of the technology specific to it. Aquablation, for example, we need that data. With that said, globally, what's the number one deobstructing surgery being done? TURP. So that data globally still has applicability. But yes, we do need that data, and that's going to start now, and you guys designing it together as a cohort and making those plans that when you hit research year, looking retrospectively, cohorts, or prospectively, but that data does need to be achieved.
Yeah. Another point that my mind is going, being, mostly working in oncology, is BPH impact on bladder. How about all the prostate treatments that we do and the impact on the bladder ductal?
Absolutely.
Have you looked into this?
No, so I was talking to Chris Wade about that, and I'm working with other oncologists in the East Coast, because we do feel that with this very easy one-page questionnaire that can capture especially urgency incontinence, it has a strong chance of influencing the choice of radiotherapy or not. These guys who we capture very quickly are very high storage subscores in stage 2. That discussion, it'll shape and reshape shared decision-making about radiotherapy versus surgical therapy. You're exactly right, and that's where we're moving next. The other area is actually reaching out to primary care and working very hard to find the correlate for them to see that connection between blood pressure, hypertension, Qmax, and bladder health.